Hi, I'm Dr. Jo Taylor. I'm a researcher in the Mountain House Research Centre at the University of York. And in this presentation, I'm going to tell you about a recently completed study that we've carried out to explore polypharmacy. So this refers to taking multiple medications in children and young people with a life-limiting condition. So I'm going to start by telling you about why we thought it was important to carry out this research. I'm going to tell you what we did and present some key findings, and then I'm going to finish by thinking through what does this mean and what are the next steps in terms of taking this forward. So why should we focus on this? Well, whilst we know that polypharmacy is a lot of the time appropriate, and certainly for children and young people with a life-limiting condition, it will often be appropriate for them to be taking multiple different medications. We also know that polypharmacy is potentially problematic. So we know that people who take multiple medications are more likely to be taking a medication that isn't benefiting them or a medication that they no longer need. We know that drugs interact with each other in sometimes unhelpful or harmful ways. Drugs can also interact with diseases or health conditions. We know that medication errors are more likely among people who have polypharmacy, so those who take multiple medications. We know that people who take multiple medications also struggle with adherence in terms of following the instructions to take them when they're taking lots of different medications every day. And medication burden is also an issue for people who have polypharmacy. And so for children and young people who will be taking multiple medications each day, this can impact on the quality of their life and also the quality of life for their parents. So we started by having a look at the existing research, existing literature, and there's a systematic review that's tried to find all studies that have looked at polypharmacy in children, and there's very, very little evidence about children with life-limiting conditions. So there's a couple of studies from North America, and there's a couple of children's hospice audits from the UK, and these suggest actually that children with life-limiting conditions do take quite a large number of medications, but they're quite small. And the North American ones, it's usually like from a single hospital or a single service. So there's no robust research that even starts to tell us how many children with a life-limiting condition have experienced polypharmacy and what that polypharmacy looks like. So this first study that we've carried out really tried to build up that picture, so to describe prevalence, in other words, the numbers of children who have polypharmacy and explore the patterns of that polypharmacy. To start to explore what appropriate and problematic polypharmacy might look like for this population, and as I've mentioned at the beginning of the presentation, to identify priorities for a future research programme, if that was what was needed. So to describe prevalence and patterns, which is what I'm going to present today, we used prescribing data from primary care, so GP prescriptions. And we used one database of primary care data called the Clinical Practice Research Data Link. If you want to learn more about that particular database, I've included a couple of links on the slide. But overall, it gives us a representative sample of the general population who are registered with a GP in England. So our sample consisted of children diagnosed with a life-limiting condition who were aged 0 to 19, and obviously they had to be registered with a GP in England taking part in CPRD, and they had to be registered and taking part in CPRD between the years of 2000 and 2015. And this gave us a sample of nearly 16,000 children and young people, around half female, half male, lots of different life-limiting condition diagnoses. Ages of diagnoses varied, but the mean age of a diagnosis was 3 years old in our data set. Nearly a third had more than one diagnosis of a life-limiting condition, and actually around half had another chronic condition, so something like diabetes or epilepsy or asthma. In terms of defining medication items, so what we wanted to do was count medications for each of these children in each of the year that we had data for. We initially used drug classes to count medications. So a drug class is something like an opioid analgesic is a drug class. Actually, when we presented our preliminary findings to clinicians and families, they told us that actually using drug classes is really likely to underestimate polypharmacy for these children and young people, particularly around the medication burden aspect of polypharmacy. So, for example, some children might be taking several anti-epileptics or several opioid analgesics, and the way we'd counted medications wouldn't have captured that. So we decided then to use a specific CPRD code called the product code, which gives us the individual drug formulation. And we also looked at what other studies about polypharmacy had excluded and excluded similar non-medications, vaccines and so on. There's no clear sort of picture about how we define polypharmacy either. The definition tends to be very similar across all the different research that's looked at this in different populations, so the concurrent use of multiple medication items by one individual. How everyone sort of operationalises this in different ways. So we can either look at unique medications or regular medications. So unique medications would include like one-off prescriptions, for example, for an antibiotic, whereas a regular medication wouldn't count those as medications. And a lot of the research about polypharmacy in adults tends to use this sort of 5 or more medications as being polypharmacy. More recently, a report suggests actually if we want to identify patients who are at risk of that more problematic polypharmacy, then perhaps we should be thinking about 10 or more medications. So if we think about the sort of risk of medication errors, the issues with adherence and burden, how drugs interact, actually that maybe we need to be looking at a higher number. The research about children tends to use quite a lower number, so a lot of that research will just go for 2 or more, and it varies in terms of whether it looks at either unique or regular medication. So we decided to look at all 4 in terms of what it tells us about prevalence of polypharmacy for children with a life-limiting condition. How we could find regular medications was really tricky, and there's no easy way to do that with the data that were available to us, because there's lots of missing information about whether a medication is regular. So in the end, we went back to existing research about polypharmacy and used what that research has done. So we defined a medication as a repeat medication if it's prescribed again after 121 days. And then we defined it as a regular medication if there's a sequence of at least 3 repeat prescriptions. So how many children have polypharmacy? So if we think about the most common definition that's used, around a third of children are prescribed 5 or more unique medications each year. If we think about that definition that's associated with the more problematic polypharmacy, around 1 in 10, so around 10% are prescribed 10 or more unique medications in each year. Actually, the average is around 3, and the range varied a lot. So actually quite a number of children were taking no medications each year, and through the whole period of time, so 2000 to 2015, around 11% actually had no prescribed medications for that period. And children, varied in terms of how long they were in the data set for. We also carried out some analyses to explore what factors are associated with polypharmacy. And we could only look at factors that were available to us within the data set. But it did tell us that children with particular conditions, so children with respiratory, metabolic or neurological conditions, are more likely to experience polypharmacy. Children with comorbidity, so that's having another life-limiting condition or having a chronic condition alongside a life-limiting condition. Children with more hospital admissions, and children from the most deprived areas. This actually suggests that children with cancer are less likely to experience polypharmacy. However, because we're using primary care prescribing data, it's likely to underestimate the medications that they take, some of which will be prescribed from specialist hospital teams. So, what about other factors that we weren't able to explore in this initial study? So we carried out a couple of workshops with clinicians and families, and here's sort of a highlight of some of the discussions that took place in those workshops. So rather than thinking about children with particular conditions, there was a lot of discussion around children with medical complexity as being at risk of that potentially problematic polypharmacy, and children with difficult to control symptoms where drugs might be added and they're added by different prescribers. And this links to some other sort of barriers related to families and clinicians in terms of barriers to stopping medications that have been started by someone else, or medications where a child is stable and actually to remove one there's a risk that they might deteriorate, even though a prescriber suggests that that medication might not be benefiting them. We also talked about how children with a life-limiting condition are perhaps unlikely to have regular medication reviews, and that therefore drugs might accumulate over time. And this really highlighted to us that one potentially problematic polypharmacy is something that we need to explore in this population, even though for a lot of children with a life-limiting condition, polypharmacy is appropriate. But we need to really understand the complexity of what's happening around polypharmacy. And to do this, the next step really is to carry out a qualitative study with parents and young adults and clinicians to understand some of those wider factors that are influencing polypharmacy.